Today we'll be discussing clinical epidemiology. Our objectives are to describe the scope of clinical epidemiology, describe the importance of clinical epi in providing high quality and efficient care, and discuss how measures of screening tests like sensitivity, specificity, and so on are used to make clinical decisions in practice. The motivation for clinical epidemiology is well summarized in this quote from Noel Weiss's Clinical Epi book. He says, ideally, the provision of healthcare would judiciously employ effective tests and treatments that have a minimum of untoward consequences. So the question is, how do we do that? Well, in part, we use clinical epidemiology, and this is the study of variation in outcomes of disease and the reasons for that variation. So it's a branch of the broader field of epidemiology and uses many of the same concepts and practices, but it focuses on questions of clinical importance. So we use evidence from observational and experimental studies to inform clinical decision-making. This really centers around diagnosis, testing, and intervention, and choosing which ones are most appropriate in each situation. We also need to evaluate causation, and this basically leads us to what is known as evidence-based clinical practice. In clinical epidemiology, one difference from the broader field is that our population of interest is almost always a group of people with a specific condition or set of risk factors or health system exposure. So in other words, the denominator that we use for our population and risk calculations is some subpopulation of patients. Two broad questions fall within the scope of clinical epidemiology, the first of which is, should we test a patient? So these kinds of questions could be those that are listed here. So does FOBT discriminate between patients who are and are not likely to die from colorectal cancer? Does treating patients earlier based on their FOBT screening result in better outcomes for the patients, rather than waiting until we see symptoms of disease? And finally, do the costs of screening with FOBT justify the benefits that we gain? The second broad question that clinical epidemiology often seeks to answer is, should we treat a patient? So, for example, does surgery result in better outcomes like quality of life and survival than no surgery? Does chemotherapy result in better outcomes for patients who have colorectal cancer? And again, do treatment costs justify the benefits gained from doing the treatment? We talked in an earlier module about screening programs and things we consider when deciding whether or not to implement them. The first is looking at the sensitivity and specificity of the test itself, where higher is better. We also want to make sure that there is a high enough prevalence of the disease in the population that our screening tests will be meaningful. We'll come back to that in a minute when we talk about positive and negative predictive value. We also want to consider how difficult and costly it is to administer the test, how acceptable it is to patients. Also, the disease severity, so if it's not a very severe disease, it may not be worth screening for it. And finally, we would only screen for diseases that have some sort of treatment available, and we also should ensure that this treatment is accessible and acceptable to patients. So sensitivity and specificity, we talked about this in Module 2, but we'll quickly go through this again since they're the foundation of some other measures that are used in clinical decision-making. And these are really just measures of how good a screening test is at distinguishing people who have disease from those who don't. So sensitivity is the probability of testing positive given that someone truly has a disease. It's calculated as the number of true positives out of true positives and false negatives. And specificity is the probability of testing negative given that someone does not have disease. So that's calculated as the true negatives divided by the true negatives plus the false positives. And here we just show those same calculations based on a 2x2 table. So again, sensitivity would be the true positives, or box A, divided by all of those who truly have disease, A plus C, and so on. We then use the sensitivity and specificity values to calculate the positive and negative predictive values of a test. And so this gives us some more information to decide whether or not we should use one. The positive predictive value tells us the proportion of people who test positive and truly have disease, while the negative predictive value tells us the proportion of people who test negative and truly don't have disease. So this is influenced by the sensitivity and the specificity of the test itself, but also reflects the prevalence of disease in the population. So positive predictive value gets higher as we have higher prevalence of disease in the population, while the negative predictive value decreases as the prevalence goes up. And that's illustrated on this figure from the textbook, figure 3.6. We see that the same test is used across all three of these scenarios. It has a sensitivity of 80% and a specificity of 90%, which is pretty good. But we see that when the disease is very common, the positive predictive value is quite high, 0.89 or 89%, but it drops to just 7% when the disease is rare in the population. So if we have a very rare disease, an uncommon disease in the population we're looking at, even with a very good screening test, we're not likely to get very efficient results out of it. Some additional measures that we can calculate using information from tests are the likelihood ratios. We have not talked about this before. So this is a measure of test performance that again is based on sensitivity and specificity, but it tells us the probability of a given result, such as a positive test, among those with disease divided by the probability of a given test result among those without disease. So we calculate the positive likelihood ratio as the sensitivity divided by 1 minus the specificity. And an example of the interpretation of this is that if we had a LR positive or a positive likelihood ratio of 7, and we were looking at whether a treadmill test could predict heart disease, that 7 would mean that people with heart disease, so with the disease of interest, have 7 times the chance of failing a treadmill test compared to people without heart disease. Another measure that we can use to make clinical decisions is the number needed to treat, and this is the number of people who we need to treat in order to prevent one case of the disease. This is calculated as the inverse of the attributable risk, also known as the risk difference. We also talked about this earlier in the course in Module 2. Attributable risk is the absolute measure of risk, so it's calculated as the incidence in the exposed minus the incidence in the unexposed. In this context, because we're talking about clinical epi, it's the incidence in those who are treated minus the incidence in those who are untreated. And so again, to calculate the number needed to treat, we just take the inverse of that number. And this is particularly helpful because we can not only see how many people we need to treat to prevent one case of disease, but we can also estimate cost using this measure because we can multiply the number needed to treat by the cost of treatment to estimate the amount of money it would cost to prevent one case of disease. So this can help us compare the cost effectiveness of different treatment options, and it's also possible to calculate the NNT and associated costs for specific subgroups of patients. I'm not going to go through intense examples here, but on page 393 of the textbook in vignette part 4, there's a nice calculation example if you'd like to see that. We can also calculate the benefit, harm, and treatment threshold in order to make more informed clinical decisions. So the benefit is just the treatment advantage, and we define this as among patients with disease, what is the difference in the outcome for people who receive the treatment compared to those who don't receive the treatment? And then harms are just risk associated with the treatment. And that's among patients without the disease, what is the difference in outcome for people who receive the treatment compared to those who don't? So these benefit and harm estimates can be useful in and of themselves, but maybe even more useful when they're brought together to calculate the treatment threshold. So this tells us the prevalence of disease above which we should treat patients without testing them first. So the treatment threshold is calculated as the harm divided by the harm plus the benefit, and we typically multiply this by 100% to get a percentage. So in other words, if we calculate a treatment threshold of 30%, then if more than 30% of the people in the population have the disease we're interested in and present with some symptoms, we should go ahead and treat them rather than testing first to confirm that they do in fact have the disease. Case study 14.1 on page 401 of the textbook goes through a nice example using some specific numbers of this concept as well. Clinical epidemiology can be helpful in healthcare management because if we use it to inform our decision-making in healthcare, it can result in higher quality care because we would be providing care in a manner that has demonstrated effectiveness, and therefore patients should have better outcomes. And it can help us provide more efficient care, because if we only perform tests that are sensitive and specific in the population that we are treating, then that can result in more effective treatment, reducing unnecessary testing and intervention. In summary, clinical epidemiology is a specialty within EPI that seeks to identify variation in outcomes of disease and reasons for that variation. It's useful in deciding how to manage patients in a clinical setting, deciding whether or not to screen for disease, whether or not to conduct tests to diagnose illness, or whether or not to perform particular treatments. Sensitivity, specificity, positive and negative predictive values, number needed to treat, and treatment thresholds are all useful measures to help decide whether or not to use a test in a particular patient population. Finally, using evidence-based clinical care can result in higher quality and more efficient healthcare delivery.